Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I'm so glad to be back in the Sunflower House. Today's episode, we have a special guest, Dr. Rachel Novik, and she is a first-year specialized women's health fellow, and she just returned from the major menopause meeting. And on this episode, we're going to talk about some of the highlights of that meeting. First, let me tell you a little bit about Dr. Rachel Novik. She is a board-certified family physician. She graduated from New York University with a bachelor's degree in social work and, interestingly, a minor in child and adolescent mental health. She then completed a post-baccalaureate degree for pre-medical sciences at John Carroll University, and then she attended the Ohio University's Heritage College of Osteopathic Medicine at their Cleveland campus, and I think that's when she became interested in specialized women's health. She then graduated from University Hospital's St. John's Medical Center Family Medicine Residency Program, where she served as a chief resident, and she helped create a women's health medical curriculum. She has a passion for working with women at all stages of their lives, and during residency, she developed a desire to focus her practice on women in their middle and later decades where care gaps exist. So she's gone from children to adolescents to now midlife women's health, and she's the mom of a 1-year-old cute little girl, Ellie, and she and her husband just got back from a vacation in Japan. So it's been a whirlwind few weeks for you, hasn't it, Dr. Novik?
Yes, it has, but all good things.
Well, welcome. We're so glad to have you to the podcast. So tell us about the meeting and what stood out for you while you were there.
Sure. So some of the big takeaways that I had from the Menopause Society meeting this year included a lot of new medications that are on the market for hot flashes, night sweats, and bone health, as well as some recent cancer screening updates and bone density screening update recommendations. So those were the big things that I thought were worth mentioning.
That is great. Now, in terms of the realm of some newer therapies and potential upcoming therapies for hormonal menopausal symptoms, tell us a little bit about E4, estetrol for contraception, as well as menopause.
Yeah, so estetrol or E4 is a naturally occurring human estrogen found in the body during pregnancy. It has a higher activity on estrogen receptors at the vulva, at the endometrium, at the bone, and in the cardiovascular system. So it has some great long-term effects. The combination oral contraceptive pill Nextstellis, combined with is a combination progestin drospirenone, and it's a very effective form of contraception, and it is approved for women with higher BMIs, which is just another plus side and a great tool in our toolkit. In terms of menopause, E4 has been shown to reduce the frequency and severity of vasomotor symptoms, and it improves the overall health of the vaginal tissues without that same effect on coagulation markers. It's been found to be a little less heavy on the clotting side. So unfortunately, we're still waiting for E4 to be approved for a hormone therapy option for menopause, though.
So I could see maybe E4 being an option for a woman who maybe doesn't have a history of blood clots, but has never been challenged, like with pregnancy or birth control pills or surgery. And perhaps she doesn't want to go with a transdermal. She doesn't like to put stuff on her skin, or maybe has an adhesive allergy. It might make sense to pick E4 as opposed to oral E2 estradiol, perhaps. What do you think?
Yeah, I agree with that.
And certainly clot, DVTs, pulmonary embolism, which can be deadly, certainly can be side effects from higher dose oral hormone, especially synthetic estrogens. And we have a prior podcast with one of our graduated fellows, Dr. Tiffany Cochran, on contraception and menopause and hormone therapies with women with blood clots. So I'd encourage our listeners to go back to listen to that if you want more detail. So moving on to some tissue selective estrogen complexes, it's kind of a new, old, but still relatively new option. Duave, which is the brand name for conjugated estrogens orally with basidoxifene. It was really a great breakthrough, especially for women with breast tenderness, women very sensitive. And then, unfortunately, Pfizer had it off the market during the pandemic when it was busy making all of its COVID injections. And just this past June of 2023, it came back on the market. So talk to us a little bit about these tissue selective estrogen complexes.
Yeah, so these TSECs, as you said, are a combination of a selective estrogen modulator, or SERM, and conjugated estrogen, which helps provide the relief of the vasomotor symptoms. It provides bone protection and allows for endometrial safety without progestin. So that's a really big benefit that we now have an option like that. Combination basidoxifene and conjugated estrogen, or Duave, as we just said, has found that patients have had a significant reduction in the frequency and severity of their vasomotor symptoms. Again, the increased bone mineral density and decreased bone turnover compared to the placebo, and then lower rates of endometrial hyperplasia and higher rates of amenorrhea in those patients on the medication. Patients also reported improved vaginal dryness and less painful intercourse. So other benefits that aren't always seen with some of the other hormone therapy oral options.
So for our Sunflower House listeners, amenorrhea would be lack of bleeding or spotting. And certainly once women are into menopause, most are happy not to be bleeding or spotting anymore. So moving on to one of the hottest topics in terms of treating hot flashes without hormones is the new NK3 receptor antagonist, fezolinetant, which is branded as Veosa, 45 milligrams daily. That was approved for use in the May of 2023. So this is the first meeting that the Menopause Society has had where the medicine has actually been available, as opposed to just all the research that's been presented over the last several years. So tell us what some of the highlights with Veosa are.
Yeah, so Veosa was a very hot topic at the menopause meeting. Everyone was there talking about it. So it is, as you said, an NK3 receptor agonist that blocks NKB which triggers vasomotor symptoms such as hot flashes. Studies found that taking the medication had a significant decrease in frequency and severity of vasomotor symptoms in as little as 4 weeks, and they saw an additional improvement in symptoms at about 12 weeks as well. The things to note were common side effects of abdominal pain, diarrhea, insomnia, back pain, and also hot flashes. One other thing to note was that patients who have significant kidney or liver disease and patients taking other medications that are what we call CYP or CYP inhibitor medications should avoid Veosa. And physicians need to monitor liver enzymes at a baseline level and then 3, 6, and 9 month intervals.
Right, because placebo had a 1% chance of increase in liver function changes. And I guess with Veosa 45 milligrams, it was like almost 2%. It's interesting, though, in this study, women, many of them drank coffee and some of them were cigarette smokers, which do also affect the CYP cytochrome P450 enzymes, and there didn't appear to be any changes. So I think with the exception of really certain strong drugs, like some of the psychiatric drugs, I'm thinking of Cerazone and any other medications come to mind where you would probably not want to prescribe Veosa for hot flashes?
I don't think I ever got a complete list. And I think I struggled to get that feedback from Veosa when we did speak to them one-on-one.
Well, actually, there are a couple of different tables that people can find. I do think we need probably better information for busy clinicians that are prescribing medications, especially in people on lots of different medications, any psychoactive medicines, blood thinners, transplant, really complicated patients. I would say that people that want more information about prescribing and knowing what the latest research on the NK3 receptor antagonist and a future NK1, NK3 elinzanetant, which is not on the market but is exciting for us to follow the research, should tune in to some of our earlier podcasts in season 1. And those were interviews I did with researchers and physicians, which actually are available for free medical credit on menopauselearning.com or Convey Medical app. And so that, I think, it's a big advance. We don't have a whole lot of experience yet with prescribing Veoza, and with any new medication, it's always an issue in terms of getting coverage. And that can sometimes be tricky in applying copay cards. I always encourage all of our listeners to listen to the podcast on how to save money on medicines, or if you want to read about it with the links, go on our speakingofwomenshealth.com site. So you're listening right now to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health, and also the Specialty Women's Health Fellowship Director, of which Dr. Novik is one of our 2 current first-year fellows, and we're still in interview season for our next academic year. So moving into some other topics, Dr. Novik, tell us some of the cancer screening updates and guidelines, because cancer is the second leading cause of death in Americans after heart disease, and we always want to be up to date on the latest cancer screenings.
Yeah, so there were general updates for cervical, ovarian, and colon cancer screening. To start off with cervical cancer screening, per the 2020 American Cancer Society guidelines, cervical cancer screening should begin at age 25 and be continued until 65. That being said, the ASCCP, I believe, still recommends at 21. So there is some differentiation there, but the American Cancer Society has started recommending at 25. At 65, patients can discuss with their clinician when to continue or when to discontinue screening based on their prior results and their history. The preferred method of screening based on the guidelines is a pap smear with primary HPV testing every 5 years. And then management of these results, whether they're normal or abnormal, will be based on risk factors as well as the results themselves, both the pap and the HPV results.
I would say about pap smear screenings that guidelines are kind of like the bare minimum. Certainly they're not the maximum. And I always encourage physicians and nurse practitioners and physician assistants and everyone in the healthcare arena to always exercise judgment. And I'm going to hopefully have a future podcast all about cervical cancer with Dr. Sharon Sutherland, who heads that big initiative for the Cleveland Clinic. But I would say if someone's immunocompromised, if you don't think you might not see them back again, even repeating the PAP and HPV in 3 years is something that I frequently do. And when in doubt, it's best to refer for colposcopy, which we'll talk about, which is a microscopic view of the cervix. I think in the past, women were always used to coming in for their every year PAP. And even though we may not do a PAP every year, and we may or may not do a pelvic exam, every woman needs a visit with their healthcare clinician once a year. Tell us about the guidelines for colon cancer screening, which we're seeing a spike in younger people.
Exactly. So that is why it's been even more important to start to update these guidelines. So based on the most recent USPSTF guidelines, colon cancer screening should begin at age 45 and continue until the age of 75. At 75, it's again a conversation with your physician to discuss whether or not it's recommended to continue or discontinue screening. The 2 most common types of screening are the stool-based tests, and then which are the Cologuard and the FIT test, and then a colonoscopy. The colonoscopy is still the gold standard. And then the frequency of screening depends on the type of examination as well as the results. if you end up having a positive Cologuard or a positive FIT test, you're going to end up with a colonoscopy. So some patients would prefer to just get the colonoscopy and not have the added stress of a positive test.
And I think one way of doing that is if you've had a colonoscopy or two and you don't have symptoms or a family history and you're getting older, then maybe moving on to the Cologuard DNA-based test. Can you talk about cell-free DNA for cancer screenings?
Yes, so cell-free DNA is a blood test that looks for genetic variations associated with the different diseases or different markers. So it can test for circulating tumor DNA, and it has the potential to be used as cancer screening, cancer detection, as well as to monitor treatment selection.
Now, ovarian cancer, I know, is always kind of a hot topic because it's so devastating and it's potentially deadly. I don't think a lot of women realize that removing the tubes completely, salpingectomy, not just tying the tubes for contraception, but totally removing them, actually reduces ovarian cancer risk, since ovarian cancer mainly starts in the tubes, and also prolonged hormonal contraception. Not the implants, not the IUDs, but actual hormonal contraception that suppresses ovulation reduces ovarian cancer. But unfortunately, we don't really have any ovarian cancer screenings. Is that right?
Correct. So unfortunately, even though it's the second most common GYN cancer, it's still, and it is also the number one cause of mortality among the gynecologic cancers, we still don't have a good screening for it. And the lack of detection makes it difficult to diagnose.
But certainly women that have early satiety, bloating, pelvic changes, any abnormal bleeding pattern should certainly seek medical evaluation and attention. And what about endometrial cancer or uterine cancer? I know every day our busy triage nurses and care coordinators take calls from patients with bleeding. And so many of our patients like to say, well, I stopped bleeding, so does that mean I don't have to come in? I don't need an ultrasound. I don't need an endometrial biopsy. What would you say to those women who are busy and really don't want to come in for a visit?
So with our postmenopausal patients, if you're bleeding, then it's cancer until proven otherwise. So we say, get an ultrasound, get that biopsy, and make sure everything is still, your endometrial thickness is looking where it should be, so not too thick, and we're not seeing any other cause for bleeding. So we always say make time to get all of that done, because definitely abnormal bleeding in a postmenopausal patient is serious, can be serious.
Yeah, I think anytime you're over 40, and certainly families that have early cancers, Lynch syndrome, any genetic mutations that are known to increase cancers may even need to be screened sooner. Certainly, we accept some bleeding or spotting in the first 3 to 6 months of a continuous combined menopausal hormone regimen, but after that, it's abnormal. Certainly, if you stop therapy or miss pills, it's abnormal, but once you bring that to our attention, we are obliged to rule out that 1% chance of endometrial cancer, and it's usually curable, so it's something we really want to get right on, I would say. So before we move on to talking about one of my favorite topics, osteoporosis, which, by the way, I just found out that we were named one of the best osteoporosis podcast, so that was exciting. Just to go back to Veoza, so I mentioned Cerazone or fluvoxamine, which is a antidepressant OCD medicine that can affect and increase Veoza concentrations. The common antibiotic ciprofloxacin, or Cipro for urinary tract infections, is another one. The antiarrhythmic mexilatine is another one. And acyclovir, which many times is used for herpes, and lots of medicines that go through the liver may affect the concentration, including oral contraceptives. Although generally speaking, we do not use Veoza in premenopausal women, so you wouldn't be using hormonal contraceptives with Veoza. So now moving on to osteoporosis, tell us what some of the latest new therapies for osteoporosis are.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
Yeah, so we know osteoporosis can affect many women in the first 5 to 10 years of entering perimenopause, and we need to consider, or physicians need to consider, medications to help prevent that rapid bone loss. Right now, the Menopause Society recommends hormone therapy, Duvet, for healthy, younger menopausal women. And then bisphosphonates if estrogen is contraindicated or not tolerated. Then there's also raloxifene to be used, or Evista, if breast cancer risk is a concern. So those are their recommendations. I know, Dr. Thacker, sometimes you use raloxifene a little more often than the bisphosphonates, it seems.
Well, earlier on, particularly if they're not at high risk for hip fracture and they don't have hot flashes and there's no risk for blood clots, because the raloxifene acts on estrogen receptors. So my goal always is to try to have women on hormone therapy because we know it prolongs life. And we are hoping to get really long, healthy lifespans for our midlife women. And if you're going to use, 10 years of hormone therapy and the woman is still relatively young, but not on hormone therapy, maybe she's been bleeding, maybe she doesn't have hot flashes anymore, then before getting of advanced age or much higher risk for hip fracture, I like to use Evista. And it also is FDA approved to reduce breast cancer diagnosis by 50%. Certainly, if a woman is on prednisone or steroids or glucocorticoids, those classes of hormonal receptor medicines just aren't strong enough, and you need to move to a bisphosphonate like Fosamax or Actonel or intravenous zoledronic acid known as Reclast or Zometa, or even potentially the rank ligand inhibitors, denosumab or Prolia. Was there much discussion about Prolia, rebound fractures when people don't keep their appointments for their shot every 6 months plus 1 day?
There really wasn't, actually. And I think part of that's because I believe the year before it was a very osteoporosis heavy Menopause Society meeting. But I know that you and I, and in some of the lectures that we've gone to, have talked about how there's some hesitancy around Prolia and missing that immediate follow-up, and people needing to be on medication to help prevent the rebound fractures.
Yes, if I have a woman who's transitioning off of Prolia because maybe she has corrected a lot of underlying conditions and improved a lot, I usually will like her to get at least a bisphosphonate afterwards, or if there's renal insufficiency and that can't be done, something else to help bridge as opposed to just going to nothing. And I know that sometimes when people change their insurance or they go to a Medicare Advantage program, if the copay gets expensive, or if a woman has had improvement in her bone density, sometimes she just thinks, oh, I don't need to go back anymore. I've got other things to deal with. And we really don't want that, because if you're not on something to prevent that rapid bone loss, that's going to happen. So let's talk a little bit about some of the screenings and the diagnostic tests for osteoporosis. Tell us about dual energy X-ray absorptiometry.
Great. So dual energy X-ray absorptiometry, or DEXA, is the gold standard for assessing bone mass and fracture risk. The USPSTF recommends screening women starting at 65. However, as we already noted, most women lose that greatest amount of bone mineral density in that first 5 to 10 years after perimenopause. So we're missing the majority of women. We're seeing them after they've already hit that 10-year mark. So scanning them roughly 2 years after menopause is not unreasonable, and I know that's what you tend to recommend, unless there's other risk factors at play in addition to.
And tell us about vertebral fracture assessment, which can be done at the same time the 10 or 15-minute painless bone density test is done.
So the vertebral fracture assessment, or the VFA, assesses the vertebral fractures using the DEXA densitometry. It analyzes the fractures along with bone mineral density, and gives you a view to look at, are there additional compression fractures or spinal abnormalities. And this can lead to additional diagnostic information to, on fracture risks such as compression fractures, and ultimately change your treatment.
And tell us about trabecular bone scoring. I know that we had a poster presented with our research where we looked at a whole year of women scanned and found that 16% had their diagnosis changed, 5% to the better and 11% to the worse by looking at the bone architecture.
Yeah, so TBS measures bone quality, and it uses, again, the DEXA spine images to or the DEXA images to assess the microarchitecture of the bones, and independently predicts fracture risk. And it gives us an adjusted bone mineral density based on that microarchitecture. So this information can also be, again, important to help decide if there is bone degradation. Do you want to be, as a physician, do you want to be more aggressive or less aggressive in their treatment plan based on whether that adjusted score changes the patient into an osteopenia or osteoporosis or normal bone density category.
Yes, I think it's very helpful. And certainly if you're trying to make the decision whether you want to use expensive daily shots or monthly shots of bone builders, when you have very degraded architecture and low T-scores, I think that helps make the case for insurance. And speaking about insurance and patients on Medicare who sometimes stop treatments because the copays change and get more expensive, I would encourage anyone in the osteoporotic realm who's interested in this or is thinking about Medicare or is on Medicare and is going through the open enrollment. Sometimes the lower monthly premiums doesn't translate to less money overall because there can be much higher copays for medications, especially biologic ones. And we had a podcast with an expert on how to select your secondary Medicare insurance. So in wrapping up, talk about some other newer screenings, this impact microindentation, IMI.
Yeah, so there's this IMI, which is a direct measure of bone material properties. In IMI, the physician would insert a small probe into the surface of the tibia and measure bone mineral strength index, or BMSI, which is basically the distance that the probe extends from the surface of the tibia. The lower the BMSI, the greater the risk of fracture. I do not think this is very commonly used. That was the impression I got. One, because it's an invasive procedure, and we have nice, easy imaging options.
Correct. And what about this finite element analysis, FEA?
FEA uses high resolution quantitative computed tomography, or basically to create a 3D image that allows for a non-invasive evaluation of bone stiffness and bone strength at the tibia and the radius. The FEA is the most predictive imaging option, more so than DEXA, but it's not FDA approved or widely available.
So when do you anticipate maybe this might be integrated into future clinical practice?
They didn't give a good timeline, and I don't know if you have a better idea of that, but it sounded like more research was being done, and this might be something in the next 5 years or so.
Yeah, that's what's so fun about going to the menopause meetings is you hear about things that are pretty far off, 5 years, maybe 10 years, maybe even longer, but at least you get kind of a head start in terms of understanding the pathobiology, the physics, the clinical applications. Did you see anything on the phase 3 trials of the DHEA vaginal ring?
I didn't, and I looked
Okay.
for it because we had talked about it, but I didn't see anything. No posters, no presentations.
Oh, that's too bad. Because certainly we prescribe a lot of vaginal DHEA in suppository form, sometimes cream, but mainly suppository, and it can be messy. And when I thought about how great to use the silastic ring, like is used with estrogen for vaginal atrophy, called a string, and then I looked it up and found out that someone had already beat me to the patent. I realized, well, I can't be studying it because it's already in progress. So I'm really looking forward to that innovation because we always need more options and more innovations. But thank you so much, Dr. Novik, for joining us today in the Sunflower House to talk about some of these highlights. And of course, I'll have you back next year after next year's meeting, where hopefully you'll present some of the research that you're going to do on osteoporosis and bone health and maybe other topics as well. And maybe we'll have you back even sooner. So I would like to also thank our listeners for joining us in the Sunflower House. And if you've enjoyed this episode or you want to help support the podcast, please share it with others or donate to our nonprofit, Speaking of Women's Health, or at least leave us a 5-star rating and review. If you want to catch all the latest from me, you can subscribe to our podcast on Apple Podcasts, Google, Spotify, TuneIn, or wherever you listen to podcasts. It's free. Just hit the subscribe or follow button. And thanks again, and I'll see you next time in the Sunflower House.